Welcome to Raaonline. One major with two minor criteria, but there must be definite evidence of antecedent infection with streptococcal sore throat within the previous 45 days, which is proven either by throat culture swab positivity. If we catch it early, before 2 weeks before the acute rheumatic fever, we might have throat culture positivity, which occurs only in 11% of patients. Most of the patients, they don't even remember that they had a throat infection. Or during the acute rheumatic fever, you can have a positivity of anti-streptolizin O titer. 240 is taken positive for adults, while children must have more than that for diagnosis. While ASO is equivocal, or it is not suggestive of positivity, but you still have a doubt it is acute rheumatic fever, then you can do anti-DNase B, which should be more than 300 to be taken positive for acute rheumatic fever. So we'll see one by one. Carditis, which is the most dreaded complication and which we see commonly later in the disease course. There are many complications of carditis because of rheumatic fever, the commonest being mitral stenosis related complications, atrial fibrillation, stroke, pulmonary hypertension. And any amount of regurgitation of mitral aortic valve can cause heart failure. And death is a complication because of early disease of the valve or severe disease requiring surgical therapy. So, carditis to be included as a major criteria, it should have all the three components: endocarditis, myocarditis and pericarditis. So, endocarditis presents as usually as mitral regurgitation, because in earlier trials, all clinical trials, only apical pansystolic murmur is a diagnostic criteria for echocarditis in rheumatic fever. So, that is a bare minimal involvement of endocardium, that is mitral regurgitation. Other involvement of endocardium can be aortic regurgitation in the form of blowing character, EDM, early diastolic murmur. And the Carey-Coombs murmur, which is a very rare murmur, mitral stenosis murmur. Usually mitral regurgitation happens in acute rheumatic fever. You get mitral stenosis murmur in acute rheumatic fever. It is also called as Carey-Coombs murmur. There is no actual stenosis, but because of mitral valvulitis, valvular edema, the area of the valve is lesser for the amount of the blood pump. So, that murmur is called Carey-Coombs murmur. So, these three murmurs are very common in the endocardial involvement. What is the pathology in the endocarditis in acute rheumatic fever? This pathology is called Askoff nodule, very important pathology in most of the major criteria. Wherever you see a rheumatic manifestation, except for chorea, except in CNS, wherever you see a rheumatic manifestation, this is the pathology called Askoff nodule, which is the presence of fibrinoid necrosis, and this necrosis is surrounded by histiocyte, which is a combination of a histiocyte and macrophage with multiple nuclei. This is called Rowleyed cells or Anitzko cell, and it is surrounded by T lymphocyte and macrophages. So, these three pathologies should be there. One is a fibrinoid necrosis in the middle, which is surrounded by, this is a multinucleated histiocytes or macrophages surrounded by normal immune T lymphocytes and the macrophages. This is a pathology present in the valve. This is the acute rheumatic fever involved valve. See, around the cardia, there are many Askoff nodules. So, these nodules are temporary. They are very evanescent. In that, it is evanescent like erythema marginatum. If you see erythema marginatum, it will be there in the morning. By the time we examine in the night, it won't be there, or it would have expanded. We usually don't see because erythema marginatum is seen in only white-skinned people. So, it's very rare for us to see erythema marginatum. It is similar. Pathology is similar in that these nodules are very evanescent. They are present in the morning. I mean, it is not as fast as erythema marginatum, but they are present only for a short period of time, like 12 to 16 weeks. So, most of the valve diseases which are because of this disappear. That is, mitral regurgitation might disappear, aortic regurgitation might disappear, Carey-Coombs murmur might disappear. So, the disappearance or appearance of a new murmur and change in the pattern of the murmur, character of the murmur present earlier is a very important feature of endocardial involvement in acute rheumatic fever. So, these fibrinoid necrosis, Askoff nodules present along the cardia, they make this cardia very loose. So, the cardia prolapses, resulting in mitral valve prolapse. So, this results in regurgitation. Not actually, there is no damage of the valve in the initial period of the acute rheumatic fever causing carditis.